Hello, everybody, and welcome back to Tactical Scrubs. I'm so excited because today we have a little bit of podcast celebrity here. We have Mr. Michael Brown, also known as the mental health cop. And really, I met him when we were in the UK. He is really well known in the space. He started this really great blog back in 2011 called The Mental Health Cop, and it just quickly gained a ton of traction, including I think you won the Mind Digital Media Award in 2012. He's been nominated for other things through the UK College of Policing, where he worked and developed a lot of the best practices for police officers dealing with mental health crisis. And he helped to design some professional guidelines and training that are now used widely throughout the country. So we're really excited to have him on here. I kind of want to get an idea, Michael, from you. Like, where did you get this idea to start, with this, I guess, mental health initiative, being a police officer?
Simple story. I joined the police in 1998, and I was just stunned at how much of the work I did was connected to mental health. Maybe I was naive. I knew I would deal with situations involving mental health, of course. I just didn't realize they would be quite as many and varied. I didn't necessarily appreciate that things wouldn't work very well in terms of the partnerships that should exist or might exist between the police and the healthcare and social care agencies that deal with those of us who are mentally ill. It just stunned me. I think 6 out of the first 10 arrests that I made in the police were connected to mental health. So in 5 cases, there were, 6 out of 10. I mean, it didn't stay as high as that. It was just an unfortunate statistic out of the first 10. But that's partly what kind of it sort of struck me, is that, 5 people out of those 10 were people arrested for criminal offences who were thought to be mentally ill and in police custody. They were assessed for their mental health, and all 5 of them were sectioned under UK mental health law and hospitalised. In one of the cases, one of the arrests, I detained somebody under mental health law. In England and Wales, it's referred to as Section 136. It's like a 72-hour sort of psychiatric hold, as it's termed elsewhere. And with that particular guy, I remember I detained him under that provision, probably about 200 yards from the front door of a major hospital. And, in those days, because I was a young officer, I was out walking the streets. I wasn't in a police car. I was out doing the old-fashioned British Bobby on the beat thing. So I kind of thought, I've now got to get this guy somewhere safe and appropriate so he can be assessed. Well, there's a major hospital up there. So the training we'd had, limited though as it was, and we'll come on to that shortly, I'm sure. But the training had said, under UK law, a place of safety that you have to take somebody to is a hospital, a police station, or anywhere else willing to receive the person. So I thought, well, there's the hospital, I'll take him there. And the shutters came down, we were turned away, they refused to help him. And they told me very confidently that the agreed place of safety that we used was police custody. That was my first introduction to the reality that my police force were taking 1,000 people a year, roughly, to jail for being ill. And we were locking people up next to burglars and rapists and murderers and thieves. Distress that they may be, further distress that they may be because of the action we were taking and putting them through. And it just kind of struck me that this isn't right, So my interest it started from that.
That's so different than here, Michael. It's like all of our patients get dumped in the ER. It's almost like we have the opposite problem that's happening with the development of, legislation and some things that you've done thus far in training is you guys were not receiving, we were receiving. So it's different. It's interesting to see the parallels there. So tell me a little bit about, so you developed this idea that, obviously this isn't the best option for people. And so then, tell me more about that story.
Right. So if you fast forward then a few years, I'd been promoted. I'd become a sergeant, and I was spending some of my days working in the police custody area where arrested people are brought. And at that point, it was still the case that 1,000 people a year were being brought to police custody under the Mental Health Act. And I had a number of experiences in custody with people detained under these provisions. But it just still fundamentally struck me that it's all a bit odd. I was also by then very interested in what we do with the other cohort of people in police custody who've been arrested for alleged criminal offences and are believed to be seriously mentally ill to the extent that they may need to be hospitalised. So in 2004, I was doing a master's degree in criminology, and at the end of that, you need a research topic to look at for your big dissertation. And I chose to look at what the police service do with criminal suspects who are mentally ill, to look at, exactly how many people are coming through, how many people do get assessed under mental health law because there are serious concerns. How many of those are sectioned? How many of those are not? What do we do with the criminal offence that was originally at the beginning of this, story that led to assessment in custody? And what you find out is that I looked at about 10,000 custody records. I literally read every one of 10,000 custody records. In fact,
Wow.
and I found out that 1,076 people had some question raised about their mental health, so almost 11%. And roughly half of those went on to get a full assessment under the Mental Health Act by what Britain calls an approved mental health professional, a mental health social worker who is allowed to make legal decisions about your admission to hospital. And
Is that like the AMP system, right? That's the AMP
that is the
system. What
AMP,
does that stand
yeah, that
for?
is the AMP. Approved mental health professional. It's a statutory term in
Okay.
English mental health law, and people refer to it as an AMP. Nothing to do with plugs or electricity. It's a social worker who's allowed to take decisions to section people. And contrary to belief, wide public belief, it's not the doctors who assess you that section you. It is the AMP who's got that legal authority. But the AMP will do an assessment in police custody with either one or two doctors, depending on the circumstances. Usually two. And if somebody needs admission to hospital, it has to be two doctors. And if the doctors are satisfied that the illness is severe enough, acute enough, and if the AMP is satisfied that there's no other way really to treat the person than admission, they can make a legal application to hospital. So 1,076 were flagged, 500 had an assessment by an AMP and doctors, and of those, 97 people were admitted to hospital, either under the Mental Health Act or occasionally they were admitted on a voluntary basis if it was felt that they
Now,
had
I would
capacity to consent.
imagine that would be one of the reasons why there's such administrative time or there's issues, because if you need two physicians and an AMP to take these patients into custody, I would imagine that's difficult or to take them to the most appropriate care area if it is a hospital. I would imagine that takes a tremendous amount of resources and funding. I know in the US, it's like a police officer just says, I'm pretty sure this person needs help, and they take them to the ER, and then we have to receive them there. So I'd imagine
Well,
that
if
that's a challenge.
yeah, it is. I mean, if the police had detained somebody on a psychiatric hold, this section 136, there they would take them directly to a hospital, whether it's a mental
Okay.
health unit or the ER. But if somebody was, sometimes people are arrested for criminal offences and it's not immediately obvious that they're mentally ill. Sometimes it's when you get into the custody block, things have calmed down. Sometimes it's information in background records that helps the police understand that somebody may have an illness. Sometimes, when people are being booked into custody, they're asked all about their health and welfare to make sure that the police can look after them properly while they're detained. And sometimes people will disclose, I've got bipolar or I've got depression. And that then causes the question to be raised, to what extent is this person's condition going to affect their detention? So there's lots of variables play into when it will emerge. And I think an interesting point, of course, as well, is that certainly in Britain, we know for a fact that people are sometimes reluctant to tell the police that they have a mental health background for the
Yeah.
purely practical
Yeah.
reason that they know for a fact if they tell the custody sergeant, look, Sarge, I've got an illness, that will double their time in police custody. And the reason is, you've already alluded to it, is that as soon as somebody says, look, I've got schizophrenia, that means the sergeant needs to get a doctor to do an initial screening or a nurse to do an initial screening of that person to determine whether they need an AMP and two doctors to assess them. And if the answer is yes, we do,
Wow.
you then need to spend however many hours it takes to get the AMP and two doctors. So it can be a clunky system. And then, of course, a practical problem in this country for decades has been that even if the AMP and the doctors get there very promptly and say, we've assessed this guy or this lady, they need admission to hospital, you then need to find a psychiatric bed to put them in. And beds in
Right.
Britain have been cut consistently for the last 30 years. The number of people being sectioned every year has been going up. So when you have increasing numbers of people that need to be sectioned and decreasing numbers of inpatient mental health beds to care for them, you end up with a bottleneck, which means that people can't always have access to the beds that they have been identified as needing. So, all of this then puts the police in a position of, well, what do we do? And, even going back 20 years, there were legal cases in Britain where the police were being legally challenged for holding people in custody unlawfully, purely because they kind of got to like in most countries, the police can only hold you for a certain amount of time under a criminal provision
Right.
before we either have to charge you with an offence or release you from you can't detain people for days on end. And what was happening was that, it's typically 24 hours in Britain that the police can hold you. Sometimes that can be 36, But if you've got up to the 24-hour point and the law says, right, for the purposes of theft or burglary, this person now needs to be released because you haven't charged them. But if the background concern is, well, this person's psychotic, they need admission to hospital under mental health law, there's no bed, therefore the AMP has not made a legal application to detain the person, that means in legal terms they're free to leave. But if they're actively psychotic or actively suicidal, are we going to just push them out into the street and tell them to crack on? That's a really difficult moral judgment, even if legally it's actually quite an easy question. So what we were finding is that in order to keep people safe and to prevent them potentially from dying by suicide, sometimes the police would just keep people detained, and they would say, right, if
that's what we
the
do.
person wants to sue me, if they want to sue me, they can sue me, but I'd rather be explaining to a civil court why I've kept somebody safe when they're not safe than explaining, for example, to a coroner in the UK why a vulnerable person was kicked out into the street and told to crack on. So, all those things, caused me to do my master's and then go to the force that I worked for at the time and say, look, I was doing this master's degree and you partially funded it, so you deserve to know the outcome of my research. We're breaking laws left, right and centre. We're not doing the best. We don't have the right partnerships set up. Vulnerable people are being criminalised and jailed. We don't have mental health places of safety for people to be taken under psychiatric law. For all these reasons, we've had deaths in police custody, we've had legal challenges. In Britain, there had been, including my force, there had been human rights challenges. In the European courts, my force had every kind of legal challenge you can imagine. And we were probably at one point the most sued, investigated and inquired over police force. But potentially fundamentally, that was because we didn't have the partnerships in place with health to make sure that we had alternatives that officers could actually access in the real world.
That's 100% what it's about, is developing open channels of communication so that when it does bottleneck, because obviously it's going to bottleneck at this point, we don't have the resources that are there. What are the things that we can do to try and open those channels of communication and let people know ahead of time, what's going on and how do we move these people? This became a passionate subject of mine, and the whole reason I met Dean and subsequently you was because the incident that I had in an ER was because when I ended up getting pretty brutally beaten was because of a lack of mental health bed flow. The guy had been in there for 6 days. He was boarding. We had multiple other patients boarding because in the US, we just don't have a place to send them at all. And they can stay in the ER for days and days on end because they're admitted. So we're billing their insurance or billing Medicare or Medicaid for the time that they're admitted. So we're getting paid. The organization is getting paid for it. But unfortunately, these patients are just kind of suffering while they sit around and then they lose hope in the system. They're like, never mind, I'm not coming back because no one's actually going to help me because there's just nowhere for us to go. So you spend some time doing this master's. You realize that there was some, obviously room for improvement. Was the department receptive of that, or did you feel like it was an uphill climb for the majority of your career?
No, initially they were receptive. So I finished that master's in about 2000. And then by then I was involved in a bit of work that a senior officer had been asked to take on, which, was to try and improve some of the partnership arrangements in the city of Birmingham specifically. And that came about because there had been a merger of health services. That there used to be 2 mental health providers in the city of Birmingham. They merged into one, and the new ops director had said, well, we need to bring together policies from the 2 organizations anyway. It would be a good opportunity to refresh things with the police, because I'm hearing from the health side that they don't think the police are responsive. And, and that's another point. It's really easy when you're a cop to sit in the police station and whinge about how there's no health-based place of safety and there's health are not responsive, and we can go to people's private dwellings and ask for mental health support for them and we never get it. That's really easy to do. It's harder as a cop to realize that some of the culture and practice of the police force is also causing problems for the health service. It didn't take long for me to start realizing some of that, because when you sit down with people to talk to them, when you shut up and start listening, then they'll tell you what is irritating them from their perspective. So you would then learn, for example, that, sometimes, you alluded to this, sometimes healthcare professionals are subject to an awful lot of violence in the mental health sector. It doesn't have to be just psychiatric hospitals. We've had, paramedics have been assaulted by mental health patients. Emergency department, A&E staff absolutely have been. And then, what will sometimes happen in policing is that, well, certainly in British policing, the police will turn up to the allegation of assault, for example, against a nurse or an AMP, and then somebody will say, oh, this guy's got schizophrenia. We were trying to do an assessment. We were trying to get him admitted, but then he's punched the nurse, and the nurse has got a fractured eye socket. and a badly, very bruised face. There's no medical reason, particularly why this guy couldn't be investigated for his liability for that offence. So we're reporting this to the police. And, there were examples flying around. The health service provided the evidence, provided the examples, where the police have effectively just said, oh, well, he's mentally ill. What can you do? If somebody is mentally ill, they won't have insight into their actions. And sometimes you hear police using sort of quasi-legal phrases like, this is a phrase out of English law, but, they won't be able to form the mens rea to commit the offence. Mens rea is a Latin term that means guilty mind. In order to be guilty of any criminal offence in England, you have to be responsible for the act that was done, such as the punch that was thrown, and you have to have a guilty mind in the way that punch was thrown. In other words, an intent to hurt somebody and without a legal justification. So, of course, you can punch people in self-defence and you're not breaking any laws at all because you don't have a guilty mind. You're trying to defend yourself against attack, for example. You can use physical force in order to arrest and restrain people, not just the police. But if your house is being burgled, you are absolutely entitled to, if you want to and you feel it's safe, to grab the burglar and hold them there till the police arrive. So there's lawful ways to use physical force on people that means you won't have the guilty mind. But the assumption was just made that if you're psychotic or you're mentally ill, that you won't be able to prove the mens rea element of the offence. Now, actually, that's not always true. And even if it is, there's still a role for prosecution.
Yeah, I think Dean had alluded to that one time in a conversation that I guess he had worked somewhere in an executive role and there had been patients that had perpetrated some degree of violence and he was kind of told, well, too bad, they're a mental health patient. And Dean was like, actually, let's look at this and make a different, maybe a different insight to that.
Yeah, I think somewhat, I'll say cleverly now, because I have the benefit of hindsight. At the time, I was just trying my luck. I was familiar with and unfortunately, Michael, it was always the police forces in this specific case. So staff would be assaulted or a patient would be assaulted by another patient. I mean, that's incredibly common now within our mental health inpatient settings. Now, obviously, the legal and the ethical thing to do when crime is committed in England is you report it to the police because they are the sole executive branch of the state that is responsible for preventing and investigating and prosecuting crime. So when a patient is assaulted by another patient, there's no choice. It has to be reported by the police. But the police would often come, and usually it would be a constable or occasionally a sergeant who was, quite well seasoned, really well intended. They were good people doing hard work. But there was this, I think, a mistaken culture where it's like, oh, there's nothing they can do because, they're mentally unwell. And I thought, how are we going to tackle this? Because that had permeated into healthcare. Healthcare staff had now started saying the same thing. And I even back then when I knew a little bit about the law, I thought, this is not quite right. I couldn't quite figure out anyway over time. I figured out that actually there's a really great case in the Equality Act where you can say that a refusal to prosecute someone just because of them having a health condition could actually breach the Equality Act. Because you're breaking the rule of law, which is supposed to be that everyone is subject to the rule of law in the UK. Now, there's arguments about whether money and high status can avoid you of that, but it should be inarguable that a healthcare condition, because imagine if we took out, let's say for argument's sake, we substituted depression with being white or black or a religion and said, oh no, we couldn't possibly prosecute this person because they're Christian or Jewish. Well, the Equality Act would say, well, firstly, that's madness. Secondly, it's a breach and the rule of law has to apply. Yeah, so I quite cleverly would make it very easy.
And I think that's a good implication because the rule of law isn't really clearly defined anyway. It's just a general theme that's kind of been pushed through English legislation since the beginning of really, law as common law. So you can kind of adopt it to what it means for you. And there's several cases where the rule of law is mentioned in different ways and what does that truly mean. So I think that's a key portion of, again, you're not a cop, you're not an officer, until you went with Michael Hovelman and got sworn in, but, deputized that one day. But you honestly, you were taking a an employee, as a manager of these employees, that I'm sure that's where it was coming from. Someone or one of your patients had been assaulted or something, and you knew that there had to be some criminal intent, because you get to know these patients. You get to know when they're,
Yeah.
they have a degree of, reasonability about them, and they're feeling a little bit better, and they just decide that this is going to be the day that they, get everybody all riled up.
Yes. Yeah. And
So
the word you've just used there is the key word. Yeah, to degree is the key. So actually in English law, when you detain, you look to renew someone's section. And even when the initial application for for the lawful detention of someone under the Mental Health Act, you have to ask yourself the question, is someone suffering from a mental disorder of a nature or a degree? Now, interestingly, in this case, it wasn't so much just that the nature. So I think what had happened with the CPS and the police, what had happened is they'd become almost overly focused on the nature. So it'd become this screening out exercise that as soon as you ticked learning disability, autism, mental health, you were almost automatically screened out, except for the most serious offences where they would look to try and put you in the forensic mental health system anyway. And actually, I think where there's been a subtle change now, probably on the back of some of the work that Michael and his colleagues have done, we focus now quite rightly on the degree. What's the degree of the mental disorder? Does this person have capacity? Were they likely to have had? And that I think is quite a common, sensible middle ground. Sorry, it reaches quite a common sense middle ground.
I wrote a blog years ago. As I was kept thinking about this, I decided to write a blog, and I think it was called Causal, Contributory, or Coincidental. I think that was the title of the blog. And I was trying to make the point that, just because somebody has a mental illness doesn't mean that it's the mental illness that's caused the offending. It might be the illness that entirely caused the offending. We know of examples of that. It might be that the incident had contributed to it, but it's not causal in that entirely direct sense. And it could be that it's entirely coincidental to the offending. And you kind of need to try and understand the relationship between the illness and the offence if you're then going to make intelligent decisions about what to do with the offence allegation. And English law, even at the level of homicide, it clearly makes allowances for this, because there are examples of patients who have been, acutely mentally ill to the level that they could be admitted to hospital under the Mental Health Act, and they've been prosecuted for homicide offences where it has then been found that despite their illness existing to a degree where they're hospitalised, they're still guilty of murder, entirely guilty of murder without any qualification. We also have a conviction in Britain called manslaughter on the grounds of diminished responsibility. And I guess the American equivalent will be culpable homicide. If you're found guilty of manslaughter on the grounds of diminished, it means that you're still guilty of a criminal offence, you're guilty of a homicide, of an unlawful killing, but that your liability for the killing has been somewhat affected by your mental illness. And there have been really, really high-profile examples of that in England, including recently, a chap called Valder Callaghan in Nottingham last year in 2023 committed some horrific stabbings. He was prosecuted for murder, and in the end, there was a plea to manslaughter on the grounds of diminished responsibility. Now, in some people's opinion, very controversial that the courts accepted the manslaughter plea, but nevertheless, that is what he pleaded to, and that is what the court said was correct, and that is the basis on which he was sentenced. And in other cases, of course, there have been people prosecuted for murder and found legally insane, which means that they're not guilty of anything because they're insane. So, in British law, you can kill people and have those three different outcomes where the illness was causal, contributory, or entirely coincidental.
One of the problems that I would see if for an officer or a nurse, whoever is responding, we've got these now mental health teams and Street Triage and all these people now that are in the mix. When they show up, they don't know at the end what is going on or what is going to go on. And I think that's where having the right training and the right policies and the right procedures and the right tools to use, so that in the end, it appears that you have done your part to identify this as it could go either way. It could go that this was very criminal in intent, or it could go that this person was very sick and I'm trying to have a therapeutic, empathetic approach. And I think that's one of the things that I've been on this journey about, trying to find solutions that meet those for all the people that I know, because I know that no officer that I've met And no nurse that I've met really wants to intentionally inflict harm on anyone. No security officer. I mean, we're not
No.
in this because we want to hurt other people. Generally, we're in this because we want to help. So I think like having good training and good technique and good resources, like for instance, like just as something as simple as switching out the cuffs from a metal cuff to a soft cuff. Like if it works and it's viable and it's a better option, it saves you a lot of hassle on the back end when you go to court and you go to these cases and you say, look, I realized that there was something going on. It's way out of my scope of practice to diagnose this person or figure out, but I had to make the scene safe first. And this is what I did. But I felt like I could use a less restrictive option, or I felt like I could use a more compassionate option because I did see that there was some kind of mental health component to this. Do you think that in your work as you've gone forward, has that been kind of a determining factor? Like obviously the end results we can't control,
Well, yeah.
but in the beginning, we need to do something to help support our colleagues.
Yeah. And I mean, in terms of end results, when there's allegations of crime or where there are crimes involved in presentations, then, most people will probably agree, for example, if the cops responded to somebody who was clearly acutely psychotic, very, very unwell, talking to people that aren't there, hallucinating, etc., if they've stolen some food when they're sleeping rough and they're hungry, and they've never really been in trouble with the police before, and they haven't been violent towards anybody, there's probably no public interest or utility whatsoever in prosecuting that person for shoplifting. It's all about getting them care, support. So, don't arrest them for theft. Detain them under mental health law if you need to. Take them without detaining them at all if you can. Get them into somewhere where you can get therapeutic care, compassionate assessment, and get their healthcare needs met. Because it's entirely possible if you then treat the psychosis, the fact that they're living rough in the park, for example, and these are real examples I'm alluding to here, you treat the symptom that led to the shoplifting in the first place. But if the guy who's done that has stabbed the security officer with a knife in the course of stealing the food, it becomes a qualitatively different thing because the risk to the public, because the security guard is part of the public, however specific the attack may have been in a context, it's still a general risk to the public that if people are intervening with this guy who's clearly unwell, they pull a knife and stab somebody. It becomes a very different thing. And UK law is structured, Canadian law is structured, I'm guessing American law is structured in such a way as to mean that, prosecution, when it's much more serious, when there's much more risk to the public, becomes justified because certainly in Britain, Canada and Australia, the criminal law alone is the route into secure mental health care. Judges in the criminal courts have got powers in the UK that no doctor in Britain has got whatsoever. And that the powers specifically are about balancing off the right of the person to get treatment with the protection of the public. And it's the judges who have to make that balancing decision, not an AMP or a doctor, albeit doctors submit reports and have a say in the process. They submit opinions to the process. But, a lot of cases are complex. The reason police and mental health, I think, is complex is because most people are not shoplifting food when they're ill at a minor cost. And most people are not stabbing security guards either. The offending is kind of in the middle range. And then there might be a background to it where the person has been in trouble with the police before. Maybe they've been arrested before, maybe they've been in prison before, but they've been arrested today for maybe the 15th time in their life. They've got a handful of convictions. Some of them are for violent offences, but not serious violent offences. And today they're a bit ill and somebody got threatened or scared. What do you do there? It starts to get a bit more complicated. Most countries have got a sort of public policy approach to this that basically says somebody has to take a judgment. And in Britain, it'll be initially the police and then it'll be the Crown Prosecution Service. Somebody has to take a judgment about when you pass over the threshold to say that the protection of the public has become enough of an issue to mean that prosecution should take place so that all of it can be properly understood and untangled in a courtroom where the courts have got access to psychiatric reports, social work reports and other background that would never be available to the police, in the immediate aftermath of an incident. Because oddly enough, if the police say to a doctor after an incident, "Doctor, can you give me all this medical information about your client, your patient, so that I can make a decision about whether to prosecute them?" The doctors are quite rightly going to point out that stuff's medically confidential.
Right.
And it can't always be disclosed to the police, but
Now,
it can be disclosed to the courts.
do you think that this kind of complex melting pot of issues, and of course that, like Dean always says, we're taking care of patients or humans in the exacerbation of the human condition, which can go on this varying scale. Do you think that's contributed to some of the issues that we're seeing in people adopting, say, right care, right person, or whatever thing that we're trying to systemize an approach that's very individual? I think that's probably, from
Well,
what
I think,
I'm seeing from the outside.
well, right care, right persons, it's the latest in a string of initiatives over about the last 15 years where the police and health services have tried to do something. And I'll say the words "do something" deliberately vaguely, deliberately ambiguously. You mentioned street triage earlier. There was an initiative where somebody said, "Look, what's going on with the police responding to patients instead of healthcare professionals? Well, if we put a healthcare professional in a car with the cop and we send them both to the incident, that'll, presumably make it better." Well, we know that it made it better in some cases. We know that it made no difference in other cases. We know that it made it worse in some cases. What we also found with Street Triage, which was kind of like the first major partnership initiative, well, certainly in the last 15 years. There were others before that, but they were usually on a local level, on a low scale. Street Triage was the first thing to be sort of ramped up nationally in Britain and rolled out. People forget where Street Triage began. It began in the northeast of England in a force called Humberside. Sorry, forgive me, in Cleveland. Right Care, Right Person began in Humberside. Street Triage began in Cleveland, and it began because the mental health area, the mental health trust in that area, were really fed up of the police overusing this Section 136 power. Their perception was that the police were using this on drunk people inappropriately. They were filling up the health system with drunk people who were never mentally ill and were never going to be sectioned and were never going to receive a mental health diagnosis. The caricature was things like, people who've had a relationship breakdown and then they've got drunk and miserable and then they've said something generically about harming themselves. So the cops have gone, "Oh, that must be mental illness because you threatened to hurt yourself because your girlfriend dumped you." And, when people were sobering up, the statistics showed that, more than 90% of the people detained under the power were just sent home with paracetamol for a hangover, and they didn't have an ongoing diagnosis. Other examples were things like students who failed their university exams and again have drunk too much or taken drugs. They've become miserable because they're going to have to repeat year 2 of their degree program and their parents have shouted at them. And all of these can sound like, cheap caricatures about what was going on, but the trust had gone to the police and said, "Look, we're really concerned about the extent to which this is happening." We fully realise that sometimes when people have had alcohol, they'll do things that mean it's probably reasonable to think about mental health as a problematic factor, but it's difficult to think about and diagnose mental health through a fog of alcohol and drugs. So can we talk about how we train your officers better and maybe you do it differently? The police refused. Interestingly, a superintendent said, "No, if somebody says they're going to kill themselves, they must be mentally ill, therefore we'll keep doing it." So the reaction in that area was to say, right, okay, I'll tell you what, how about we put a nurse in a car and the nurse can respond to incidents where the police are present and they can help the police guide them to get this right. And they can advise away from 136 where it's not necessary, push them towards it where it is.
See how it might be effective, but also I see how, like, you don't, in initial crisis, you don't, like, no amount of great nursing skill is going to make a difference when you're trying to get this person safe. Like, if it's a true mental health emergency, a true, like, critical incident, I think that was what was so attractive to me about, the Victor asset, was really that, honestly, like, you're putting more people in harm's way that don't have the training to be there. And, like, you're just kind of propagating the issue. On the other end, you're spending all this money to keep a licensed registered nurse on your payroll when you might not need them, when you're just doing initial assessment questions that could possibly be done in an algorithm, especially now with the adoption of technology and AI and body cams and all the things that we're adding on. I think now I see why the evolution is occurring to Right Care, Right Person. But what I see about Right Care, Right Person is just this jumbled mix of, like, everybody trying to do something with this framework that's really ambiguous.
Yeah, definitely. And I mean, a lot of areas that really passionately went for street triage and stuck with it for years and years have now started pulling away from it. So in fairness, I took a bit of flack from my own police force about 10 years ago precisely, and it actually ended up with things I'd said on Twitter being misunderstood and put into the newspapers, which was quite concerning at the time and quite hilarious to reflect back on, to be honest. But it was all because, discussion about these new
That's why
schemes
Dean
was
won't let
emerging.
me have Twitter.
And
Dean won't let me have Twitter for that reason.
I mean, somebody had asked me on there, saying, "Oh, I've noticed the force you work in, are they doing this street triage thing? Did you set that up?" And I said, "No, I didn't." And then there was a bit of dialogue, which ended up with me saying, "It's a new thing. We don't know very much about how it works. It hasn't been evaluated yet, because you can't evaluate something until you do it and try it. And I do
Right,
understand the
right.
role of trying things, and then but street triage was never evaluated in any meaningful way. There are some academic papers published about it, but in Britain we've got something called the National Institute for Health and Care Excellence, or NICE. And now they did a sort of quality review of evidence for street triage, and they only found 3 academic papers that they were prepared to consider as even meeting the basic requirements for academic research. And they rated them on a 5-point scale from very good to very poor. They rated 2 of them as very poor and 1 of them as poor. So it's fair for me to comment that there isn't very much academic evidence for street triage, because typically what street triage would do is say, right, we used to use 136, let's say 1,000 times a year. Then we introduced street triage, and now we use it 700 times a year. Therefore, street triage shows that we can reduce the use of 136. You think, well, okay, now go and explain Lancashire Police, who introduced street triage and found that their numbers didn't come down. Their numbers kept going up. So areas are different, I fully appreciate, but you can't say that the initiative causes a reduction, because in some areas the reduction didn't happen. In fact, a continuing increase in the numbers, on the trajectory that it was on before the introduction of the scheme continued. Many forces tried triage and abandoned it quickly. Then they tried it again in a different format and abandoned it again. So it worked very, very differently. And even the forces that really thought it was helping, like West Midlands Police and certain other forces, they eventually got to the point where they've disbanded it. Now, Right Care, Right Persons kind of emerged out of that. And to an extent, RCRP is, I think it's fair to say, it's a police-driven attempt to withdraw from the mental health space to the extent that they feel they can. And the narrative that's put across about it is the police will still be there if there's an immediate risk to life, or if there's an immediate risk of serious harm, or if there's a crime involved in the incident. Well, fine, but the emerging evidence is that they're not just turning down jobs where the thresholds are not met. The emerging evidence
That's what
is
we're
that
hearing,
police
right?
they are saying no, where people are actively suicidal, and they have, for example, walked out of an emergency department suicidal. There are incidents like that being reported. In the UK, I'm aware of at least 4 coroner's reports from inquests where they're looking at either suicide or accidental death. And they've then published what in the UK is called a Preventing Future Death Report. And the clue's in the name. At the end of an inquest, if a coroner is concerned that something has caused a death, they could issue a Preventing Future Death Report to encourage an organisation to correct something that they're in control of to prevent a future death. So it could be the coroner says your officers need more training, or your mental health trust must do something differently, or policy needs revising, or joint procedures need revising. And coroners have issued at least 4 PFDs that I'm aware of, which allude to the things that RCRP is touching upon. And, RCRP makes it, on a certain level, it makes a certain amount of sense, because it's trying to say, sending the police to a mental health incident isn't always helpful. Sometimes it frightens service users who aren't, familiar with the police or have had a bad experience with the police in the past. And that's a fair comment. I've met lots of people who, I'm absolutely prepared to believe have had a really difficult time with the police in the past. Maybe they've been restrained. Maybe they've been taken in handcuffs to a police station when that was the only option the police had at the time. I've met a number of people who said, when I'm ill, you lock me up in a cell block next to burglars and murderers and rapists and so on. And police cell blocks are not pleasant places to be. They're full of people that are often upset, drunk, violent, screaming obscenities at the police. They're difficult, challenging, noisy places, not where you'd want to be, really, if you're having a mental health crisis. And for years, the police have done that until in 2017, the law was changed to largely prevent it from ever happening. But then, going back to what I said at the very beginning about, everybody would go to jail, you countered by saying, oh, well, in the US, everybody goes to the ER. Well, we're kind of getting to that now in Britain, because the mental health capacity that should exist in the psychiatric system to allow for people detained under 136 to be taken there hasn't expanded at the rate that the use of the power has expanded.
What the cops were saying at the emergency service show was that they were just staying there in the ER with these patients because they can't leave them. So in the US, what happens is, as soon as they're admitted or they're in custody for us we sign that form and they're gone. They'll leave. And so I think that's what's happening now in A&E environments is a lot of these nurses that I'm talking to that are A&E charge nurses or A&E, upper band nurses, they're like, look, we can't manage all these people. And I think that's where we have to have those innovative services and innovative folks like you who have experience and research and have looked at the data from the very beginning, like where are the gaps that exist and how can we fill them? So Dean, did you want to comment about the NICE guidelines and just, I know that you probably did some Googling in regards to, or some NICE guidelines look up, because Dean's always preaching those to us because we don't have NICE guidelines like you guys do.
Yeah, I made a note actually about Street Triage when Michael was talking, so I wanted to look in. Something in my mind twigged. I was like, actually that, so I made a note. I make notes all the time, as I mentioned on previous podcasts, Mel, much to your chagrin. Yeah, I don't think this is somewhere where NICE guideline automatically becomes useful. I think Michael's characterized this really well as a coordinated effort for the police to withdraw from this insofar and as much as they can. I think what's obvious probably to Michael and I is that when you talk about, we can see where the gaps are. We probably know them, to be honest. And I think most of us that work in the UK do. I think where we have a disconnect here is, on the one hand, you've got people like Michael and I that made a living in working in this imperfect world, in this imperfect system, trying to lead, design, organize, manage, and deliver these really complex organizations to meet a very difficult and vulnerable group of society. So you've kind of got us on one side. Then you've kind of got two stakeholders that are at opposite ends, but actually inextricably linked. You've got the people that hold the bureaucratic decision-making and the money. So in the UK, invariably, that will be commissioners, politicians, people like. And then you've got almost an uninterested, mostly public. And in many times, the public, if it isn't affecting them directly, if it's not something they're concerned about in terms of their personal safety, they don't tend to be too active in this area. I'll pick another medical condition, cancer. Cancer in 30 years in the UK has completely transformed. If I'd been a nurse in the 70s, no one wanted to work in cancer care because no one got better. But the money, the PR, the funding got dumped into cancer. And now people literally do PhDs just in oncology nursing, and they become specialists. All credit to them. That's never happened in borderline personality disorder. That people aren't running marathons en masse for these things.
I think that's changing, though. I think that's changing. I'm like really encouraged.
But the money's not following it.
No, not yet. But I think
the money won't follow because, for a variety of reasons, but the bureaucratic function of this delivery system, whether it be policing or healthcare, will truly only look to fill the gaps when there is more outward and vociferous outrage and support from the public at large. And I think, unfortunately, healthcare and police services are victims of their own success, that they've kept a lid on something really quite risky for some time that stopped these mass, I think, to speak in such heightened terms. But we've avoided things like mass killings on the whole by people that are mentally unwell. So that means in many ways, that's why, as Michael said, we've had like 50 years of inpatient mental health beds being cut at a time where demand's never been higher and seems to grow
your nurses,
disproportionately each year.
And the nurses and the police officers will continue to do workarounds to keep everyone safe and their colleagues safe. And they'll do the things that need to be done. And then from the bureaucratic perspective, especially like the fact that y'all's commissioners have never been police officers. Like, they are elected officials. They're not usually actual officers. They don't understand like what it's like, because you can't truly understand until you've done the whole beat cop thing, until you've actually been there in that environment and you're the one that has to call something in on a radio. You really don't fully understand the visceral response or the biological response that happens to you in that environment. The same with the nurse who's in a mental health trust. And so I think like we've done our best to like mask a lot of it. And I think now people are starting to talk about it. I think the best thing, the future of mental health resources looks like the healthcare people and the police coming together in an initiative that's focused on the goal of not only the patient, but staff safety. And I think that's where you're going to see, because if you have a whole population of people that are affected, whether it's A&E, whether it's mental health trust, whether it's ambulance trust, if it's fire, PD, if they all can come together and say, hey, this is not working, we need some more support here, I think you will get a little bit of revenue flowing to that.
Devil's advocate here. Sorry, Michael, go ahead. My point
Michael.
can wait until after.
Right, I was just going to say, no, I think everything you both just said is absolutely spot on. The thing that I was going to say was about, you mentioned commissioners in England. They're very rarely at the meetings that the police go to. You know, when you have a meeting with partners, you tend to meet with the providers of mental health services. So by way of example, when we didn't have health-based places of safety and mental health units and 1,000 people a year were going to jail, we were going to meetings for ages and ages. And police didn't understand this distinction in England between the provider of services and the commissioner of services. Because in policing, we don't have that distinction. You know, the chief constable runs a police force, and he or she is the provider and the commissioner of whatever policing services you feel you need. So, you know, whatever's right or wrong with policing, the point is you can ultimately go to the man or woman in charge and say, this isn't right, fix it. And they've got all the power that they need to commission or deliver or whatever. In health, it's not like that. So the police were bumping into these rooms, and by police, I mean I was bumping into some of these rooms, and having chats with people from mental health trusts. So I was saying, oh, you know, you need health-based places of safety because everybody's going to jail and there have been deaths in custody and there's been legal inquiries. And all these professionals were nodding at me, really senior people. Yes, oh, we definitely need that. We definitely need that. You know, and I'm like, oh, brilliant. We're getting through here. We didn't have to try very hard to make this argument. And then at the end of the meeting, you go, right, so when are we going to do this then? Oh, no, we're not going to do it. Well, what do you mean? We're not going to do it. You just sat here and agreed with me for half an hour. And what they meant by that is we don't have the funding to do this because we haven't been commissioned to do it. So in other words, you know, if you think of mental health provision as an alphabet, their job was to do A, B, C, D, E, F, and that's it. X, Y, Z is none of their business because they've never been commissioned to do it by the commissioners. So you then say, well, who are the commissioners? Where are they?
As a barrier.
Yeah, it absolutely was. Then we went off to see the commissioners, and they were kind of, well, you know, we are the mental health commissioners within an organisation, which in England at the minute is called an integrated care board. And, you know, we are given by the care board, we are given a budget for mental health. And in some areas, that budget is 6% of the health budget. But in other areas, it's 16% of the health budget. So in some areas, they're given a load of money. And in other areas, relatively speaking, they're given next to nothing. And oddly enough, that ends up reflected in some of the services that you see. So the commissioners would say, well, with 6% of the budget, we've got, you know, however many millions of pounds that is for this area. We have to make tough decisions about, you know, access to psychological therapies versus inpatient mental health beds versus health-based places of safety versus, you know, children and adolescent mental health to a certain degree. There are all these different competing demands within mental health where, you know, we talk about mental health being the Cinderella service, but within mental health, they'll talk about what is the Cinderella service within the Cinderella service. There are constant tensions for budget. So in some areas, you know, perhaps because the police weren't banging the door down to say, look, this needs to change because 1,000 people a year are going to jail, some people have died, big inquiries, human rights violations, yada, yada, yada. You know, why would you change any of that if nobody's objecting to it? So, of course, eventually the funding gets, you know, sort of identified in the areas where I was working, and they set up health-based places of safety. And then, you know, within a few years, 1,000 people a year are not going to jail. They're all, and I mean all in some years, going to the health service. You think, well, you know, brilliant. But then you've got that issue about how the cops are then remaining in these health buildings for hours and hours and hours on end, if not days on end in some cases. And for example, the phase 4 of the Right Care, Right Person program is about trying to get to the point where cops are released within an hour. Because unlike the US where you sign the form and that's it, they're yours, in England, they remain in the custody, detainees remain in police custody until somebody else agrees to take them over. So if the ER
I've
nurse
noticed
or the
everybody is in these different phases, right? So like some departments are in phase 1, some departments are in phase 2, some are in 3, and some are in what I've noticed is most have not made it out of phase 1 thus far that I could see. I don't know if you probably know more about this than I do about the different phases.
My experience is most forces when this. Yeah, most forces have started by doing phase 1 and 2 together, but absolutely not all forces. Some said, yeah, we'll start with phase 1 only. Phase 1 is about the police not doing what often gets called a welfare check. You know, because it's become a thing in Britain. And in fairness, there's a kind of semi-amusing but nevertheless a bit concerning practice where at about 5 to 5 on a Friday afternoon, a lot of health and social care organisations will ring the police and say, look, Dean had an appointment the other day that he was due to turn up to, but he hasn't turned up. 2 days we've tried his mobile, he hasn't answered. We're going home for the weekend now, so can we ask for a welfare check? And they would be asking the cops to go around over the weekend and find him just to check that he's okay. And there's a kind of intuitive sense to that, because if you've got a concern that he might not be okay and he's not answered his phone, and maybe in the lead up to the appointment it's known he wasn't exactly terribly well, we want to go and check on his welfare, don't we? We want somebody somewhere to kind of try and assure us that he's okay. And that if he's not, to take some kind of corrective action to help him get okay. All of this is perfectly intuitive. But the question, I remember having to argue this for years to point it out. You can't send uniformed cops to somebody's door unexpectedly and get a valid, reliable answer about whether the person's okay. Because, in my service, in dealing with this, obviously I've been operational for most of my service. But when I've been in policy roles where you do a lot of training and conferences and others, we invite people in to talk from their lived experience of the police, to help the police understand what it feels like to be policed when you're, in distress and so on. The number of, credible people I've met who kind of said, with all due respect to the police, I'm not going to tell them the truth if I feel like I'm going to hurt myself, because if I tell them that, they're going to lock me up. Because what are the tools do the police have to keep you safe if you're admitting to them that you are immediately not safe? So I've had, patients, people with whom I'm still in contact actually on social media and other forums, who've said, when the cops ask me if I'm okay, I'm going to lie. And I'm going to hope to get away with it, because that might mean they don't arrest me, detain me, restrain me. Some of that is dynamics around, for example, female patients not wanting to be restrained by an organisation which is still overwhelmingly a male organisation. Which female mental health patients who maybe have got mental illness because they've suffered sexual trauma in the past, sometimes from authority figures, want to be restrained by male police officers that look like me. There's loads of them wouldn't want to be, and that's hopefully not a reflection on me. It's a reflection on their experience and their fear of what will happen to them when they're in distress and not well. So in that context, I remember going to a house on a I think it was a Friday or Saturday night at about 10 o'clock at night. A mental health service had said, look, we're really worried about so-and-so. Can you just go and check she's okay? And before I knew, any better, I went round to try and do my best with it. But I remember ringing them back and saying they'd implied she may be going to take her life by suicide, but she hadn't said anything too directly, but they were alluding to that as their level of concern. So, of course, we're going to have to go because we do need to check she's not dead. And so when I got there, she answered the door, but she did it by opening the door just 2 inches, and she had one of those security chains on the door. So the door couldn't open beyond that. It's dark inside her house, so I can't really see her. I can just see a sort of outline of her face. She assures me she's okay. She seems distressed. The police have been called. She doesn't want us in the property. She won't talk to us very much, and then she shuts the door. So am I able to say that
and
she's
that's
safe
dangerous
and well?
for you, right? Correct me, but from my limited policing knowledge, that can be dangerous for you because you don't know. What if it's a domestic? You can't see, you can't assess. You're at risk anytime you send an officer out to do anything like that. It's high, especially here in the United States where everybody has firearms and you can't just walk onto somebody's property. So you have a risk anytime you're doing that.
Yeah, a certain level of risk. In fairness, you would routinely do a check on the address and a check on the person before we went there. In that particular context, there wasn't a particular reason to fear that there was a particular risk. Any policing job, there's going to be some level of unknowable risk.
Right.
Nothing about this one suggested there was. Anyway, the point is, after the door was shut, I rang the mental health services back and I said, right, I've been there, I've seen this lady, I've spoken to her very, very briefly. Here's how it went. Here's what happened. She's there. She's alive. Whether she's safe and well or not, I can't tell you, because I can't say from that interaction that I'm satisfied she's safe or I'm satisfied that she's well. And all I can tell you is she's there, and I don't have a right to enter the property. She hasn't committed an offence. It's back to you, really, in terms of what you want to do next. And even though I've said what I've just said, the nurse said, well, as long as she's safe and well. So I had to say, hang on a minute. Now, I've just specifically said I can't say that she's safe and that she's well. She may well. You said she was suicidal. I can't say that she's not. She could have gone back in the house thinking, oh, they've called the police, I'm really going to end it now. For all I know, she could be in the house ending her life as we speak. Said, but there's no reason for me to think that she is doing that. I just also can't tell you that she's not doing that. It's kind of back to you, because you guys are the only people, for example, that could go to a court and get a warrant and then, revisit the property with the police in order to then establish whether or not she needs assessment or detention or anything like that. It's not something that we can do unilaterally as a police service.
Yeah. And I think that's part of the problem, Michael, isn't it? That we know that as much as these organizations do some incredible work, that there is an unintended consequence of being an extension of the state as part of these huge organizations, which is a lot of this stuff is really just about how things look administratively.
Where do you think?
And
Go ahead, Dean. Sorry.
Yeah, and I certainly saw lots of that in my time, and I think that's what gives rise to the 5 o'clock, between 2 and 5 on a Friday.
Yeah,
and it was what was always incredible when I was the operational lead for community CAMS service. What was incredible was if a staff member were going on leave the following week, the amount of patients that they'd have rated as or needing a referral to a crisis team. And it's much like an inpatient services, unfortunately. I've seen lots of PRM medication be given really to treat staff anxiety rather than patient agitation. And I think sometimes these institutions do encourage and then foster unhelpful behaviours. And I think that's really why you have to have really good leadership and really good training systems.
Do you think, what do you think the future of it all is? Like, for time, we're coming up on, almost an hour here. I think we could probably have a series of podcasts about this because, Michael, you're just a wealth of knowledge. But where do you think the future is going with all of that?
Well, in the UK at the moment, and in fairness, this Right Care, Right Person program, it seems to be spreading abroad as well. It's also, they're not using the name RCRP, but there's evidence that in Australia, they've sent senior officers from New South Wales Police to Britain to look at RCRP in London. And it's interesting that they've gone to London because most foreign forces do, because the Metropolitan Police in London, it's the biggest, it's the busiest. There's loads of reasons why London stands out because, London is such an entity and such a huge, busy police force that it's not really comparable to any other police force in England or Wales or Britain for that matter. But they sent New South Wales senior officers to look at how it's working. In New Zealand, the nursing unions have started having to protest about things that are involving very similar language to RCRP, but they're not calling it RCRP. The police over there have started saying we're only going to get involved if there's an immediate risk to life. In New Zealand law, there's something called I think it's a Section 41 request that mental health or social work services can make of the police for support to administer the Mental Health Act. And they're talking over there about the police just refusing to provide Section 41 support. So the future seems to be this idea is going to roll and more police forces are going to think it looks an attractive idea. Personally, I think, the line that healthcare professionals seem to have taken with it is, we agree with the principles, it's just the way that it's being rolled out and the way that it's being done in practice that we've got concerns about. I think I'd go so far as to say I've got concerns about the principles. For me, they seem very partial. They don't seem to be grounded in partnerships either. And whatever we think of policing, whatever we think of mental health services, you kind of got to talk to each other and understand each other a bit if you're going to get the nuances of this right. There are academics who've written at length about how partnership work at the interface of mental health and criminal justice is probably about as complicated as anything else you'll ever do in public service. And the professionals working at it, need to be really skilled, intelligent people who are aware from both sides of the fence what the issues are. The books that have said this, the academics who've written about this, they were doing it years ago. This is not a recent thing. But Right Care, Right Person, to me, feels like something that's been done to the health system rather than something that's been done with the health system, in my view. And I think the evidence for that,
I like that,
is overwhelming. When RCRP was kind of formally announced as a national thing in the middle of 2023, there was the publication of something called the National Partnership Agreement. And it was published with various endorsements to it from the UK Home Office, which politically oversees policing, from the Department of Health and Social Care, which politically oversees the health service. It was also signed up to by NHS England, the College of Policing, the National Police Chiefs Council, and the Association of Police and Crime Commissioners. So sort of 4 policing bodies and 2 sort of government bodies. Sorry, 3 policing bodies, a health body, and 2 government bodies. Now, the National Partnership Agreement, when it was published, the 3 policing bodies and the Home Office all had big press releases, social media activity, lots of stuff to say. This wonderful new partnership deal has been struck with the NHS. Look at what it's saying. And the headline was 1 million hours of police time will be saved. Then you go and look at the website. I did this on the night that it happened. You then go and look at the social media and the websites for the Department of Health and for NHS England. Nothing. Not a single thing was said by either of those organisations about this partnership programme. And if the headline is 1 million hours of police time saved, why is the headline not, this is going to be much better for the public, for patients, and getting a better deal for them with more humane care? You had to read sort of 3 or 4 paragraphs down the press release before you saw anything that alluded to better outcomes for patients and better care. And I think that's questionable whether that's actually going to be the outcome. But even if it is questionable, you probably want to lead with that, don't you? Because surely all of this is about public service. It's not about whether the police are saving time. Because right care, right person isn't talking about things where the police are under-involved and, under-effective in their mental health roles. And ironically, and it's a huge irony, it's where the police don't get properly involved and thoroughly involved in crime, which we talked about earlier. The police are too quick to sort of say, oh, well, that's just mental health. There's nothing we can do. Well, actually, there are stated cases about not taking things forward into the justice system that should have been taken forward, where patients should have been believed, or where there's corroborative evidence that the patient was a victim of crime, where it doesn't matter that they've got schizophrenia because other independent witnesses saw what happened. And it can't be just pushed off as a delusion or something that they've fabricated because of an illness. This is stuff that's gone through the courts. And if the police are going to be true to their mission about preventing crime, bringing offenders to justice, maintaining the king's peace, protecting life and property, all the things that you swear an oath to do when you become a constable in the UK, then we need people who are working at this to have a thorough and comprehensive overview of what those duties are, not to cherry pick some of the partial stuff where we think we can do less and save time. Because that's not really the point for me at all.
Yeah, I think that's quite right, Michael. I think you've summarised that really well. I think we should wrap up. Maybe we have lost Mel, who may be back with us. Michael, just before you go, obviously we've really appreciated having you here in the time. How can people engage with you, find out what you're up to, and follow your great insights?
Social media, all of it's under whatever platform you want to pick, it's under the name of Mental Health Cop. So on Twitter, @Mental Health Cop. Twitter has been the main vehicle historically that I've used, but I'm conscious people are moving away from that platform at the moment for various reasons. So there's a Facebook page under the same name, there's Threads and Instagram under the same name, but the most of the material that I do is on the blog, mentalhealthcop.wordpress.com. I publish an article usually once a week, sometimes a bit more frequent if there's stuff going on. And they're all just my own thoughts and insights, and people don't have to agree with me, but I'm just trying to stir the debate and make people think about the things that I'm not necessarily sure we are thinking about and talking about. Mental Health Cop.
I think we could have gone for at least 2 hours. So Michael, let's get you back on very soon. Mel, as always, good to see you. Michael, thank you for your time. Good to see you.
No problem.
And we'll speak to you both very soon.
Good to speak to you.
Thank you, Mike.